Y'all go.
Hey guys, it's good to see everybody here. We've got what, another 7, 8 hopping on. Oh, there's Miss Terry. She's hopping on. But thank y'all for joining us today. I have to apologize. I should have let Tom actually open, because normally by the time I'm able to hop on these, or I remember we have them, I've missed the intro, so I don't know how to start one of these things. But thank everybody for thank y'all for being here, and for those of you who filled out the survey, y'all should have gotten an email a little bit ago from Texas MGMA coming from Betty Wilkes about the responses we had. We had about 6 responses. The questions this week were, what is your turnaround time for calling on referred patients once a referral is received? How many attempts do you make to schedule a referred patient? And what is your referral to appointment scheduled rate? And then there was an opportunity for some comments. So actually, do we have the ability to share our screen, Tom, so we can show the answers here?
Should be.
Yeah, let me make you a co-host.
Okay. Oh yeah, it's allowing me.
Okay.
Share. That way nobody has to unnecessarily look at my face if I'm talking. So Betty put together this nice chart because all 3 questions obviously were very closely tied together. You can see that the turnaround time, the 6 responses are all listed here. The turnaround time for calls, you have some same day, some 8 hours, some the office policy is 1 to 3 days. I'd be interested. I think, Tom, that was actually your answer on that one. When you say the office policy is 1 to 3 days, does that mean that you often beat what the policy is, or are you struggling to get to the 3-day, or what's the just because the policy there is setting 1 to 3, what's the actual realistic turnaround there?
Well, my response to that, Justin, was it should be within 24 to 48 hours. And otherwise the patient gets impatient and may decide to reach out to their PCP for a new referral. I've always considered the referrals as a gift, because if we're a specialty clinic and a primary care doctor thinks enough about us to refer somebody to us, then I think we have an obligation to, 1, treat their patient like they're our own, which hopefully they will be. And if you can get to them the same day, that'd be great. But nothing irritates me more as a consumer than a week passes by and I don't hear a word from the referral.
Sure. Was there anybody on here that did not have a chance, missed their opportunity to fill out the survey, that wants to chime in? That's what is your turnaround time for calling on referred patients once the referral is received? Is anybody here want to jump in?
This is Terry. I apologize. I was having technical difficulties. You know, I didn't get to respond, but for Baylor, our goal is to be 3 days. I also work with our referral center team, and I've been trying to find a good goal for our organization. And so I also reached out to, there's a patient access collaborative, and you know, what I saw on with their information, it was also, they benchmark everything off of 2 days, but they measure their referral goals by being able to get those appointments scheduled and a completed visit. But I think the purpose of this first question was just how quickly are you able to call those patients? Because I know for us, sometimes it gets difficult being able to, you know, balance other duties, and then also making sure that we are reaching out to our referrals in a timely basis.
So I'm gonna hijack this question just a little bit and ask a sort of parallel question. Are most of your policies to reach back out, for those that run specialty clinics is probably the better way to ask this, that run specialty clinics, when you get the referral in from the PCP, do you respond to the PCP within 24 hours or directly to the patient, or both? What's your policy there?
Justin, from what I've seen in the several years that I've been consulting with medical practices, is that they typically will reach out directly to that patient. And then once they have the referral and the date, what they should be doing is contacting the primary care doctor, just to let them know this is when we have your patient scheduled to visit. And of course, the ultimate thing, which I have found now that I'm consuming more of our medical care since I'm older, is that I'll go see my primary care and she will not have a follow-up note or anything from the specialist that she referred me to. So it's just so important, I think, to make sure that when we get these referrals, we close that loop by one, we see the patient, we follow up with the primary care doctor to let them know our findings, or two, if you cannot reach that patient after about 3 times, many people just blow it off. And then what happens is your primary care clinic may not even know that you didn't even try to reach them after that. But I think there needs some follow-up, such as, hey, we got a referral on Tom Tidwell. We tried 3 times over a period of 4 days to reach him. He has not responded to any of our messages. We need your assistance to, have him follow up with us.
For us, we're reaching out to the patient, and then if the referring provider, if they're also utilizing Epic, then they would receive a message saying that we've seen their patient. But if they're not on Epic, we really kind of leave it up to the department on following up with that individual provider. Sorry, and it looks like my video is frozen.
It is freezing slightly, yeah. That's similar to what we do here. In our department, in our institution, if they're using or they're part of our same family of EHR, they get notification immediately when that's taking place. If it's an external referral, one of our other teaching hospitals runs Epic and we do not, we're on Cerner, then it's up to the individual clinics or the individual departments to how they respond. Historically, we were reaching back out directly to the referring provider, but we were finding there was a hiccup there where that referring provider would not pass the date and time of the appointment on to the patient. So we switched and now we're going directly to the patient, but we're not doing that last step that Tom mentioned. You mentioned about once for the externals, we're not then notifying the referring provider, so they don't have that documentation. And we've been getting more requests recently, hey, please keep us in the loop. So this was actually I really enjoyed this round of questions this week, because it's a project that I'm currently actively working on. So I was really pleased to see these questions come out.
Well, Justin, Texas Medical Liability Trust, they offer a practice review to their insureds. And I've seen them come over the years to the practices I've worked with to do things. And they do kind of focus on certain items. And one of them is it's kind of like if you're a provider, if you order a lab result, the expectation is you're going to do something with that lab result. Sure. You're looking for a reason, and therefore you should have some documentation that you consulted the patient, whether it was on the next visit or a special call if it was an elevated rate or whatever. Sure. And if we're looking at somebody's records and I say, well, I see you referred Tom Tidwell to pulmonary. And they go, yeah, well, whatever happened with that? And
sure.
If you have that documentation, because, it's so important to make sure we have the documentation.
Close that loop.
It just helps you. And then when you see that patient again as a primary care, you can say, hey, I got the note from Dr. So-and-so, and apparently, you're fine except for whatever it might be.
I have a question just kind of before we move on to the next, with regards to contacting the patient or being able to reach the patient. Just curious, how many people actually have an automated dialer where it will reach out to the patient and it's like a robo call, but as soon as the patient picks up, it will connect the patient to a live agent to schedule that appointment. Does anyone have that?
Only your place, Terry, because you guys have lots of money.
No, I don't have
money
it.
To burn.
That's why I don't have it. Duke has it though. And then
John Wayne? John
Duke,
Wayne?
The Duke.
Oh no.
Your dad jokes are getting worse, Tom.
Oh yeah, I was like, I didn't even get it. but I mean, anyone on, I mean, if you don't want to talk, or if you can chat, if you have that. Okay, I was just curious. I mean, apparently once they implemented that for their organization, I mean, they saw a 40% increase. So I was just curious if anyone was doing that.
Did they give any indication in their survey what the age of their patients were that they were doing the robocalls to?
To every patient. So as soon as an order is submitted, the robocall will contact that patient, let them know that you know, you have been referred to our cardiology department, whatnot, and if you would like to schedule an appointment now, please press 1, and then it connects the live agent to schedule that appointment.
Yeah.
But I mean, I think that's where we struggle, at least for us, is, you know, we make our 3 attempts, and it seems like from what I'm seeing, a lot of people, 3 attempts seems pretty normal, with the exception of the cosmetic surgery group. But, you know, when we're making those 3 attempts, it's if we reach the patient, right? And if we don't, then, you know, it's wasted time and effort.
Yeah, and I think it's important too that I've seen different things. I've seen people that will create an Excel spreadsheet that they share with everybody in their practice through a secure format. And then people will document every attempt that they do. And I think it's important to show, because if you go in there to look at it as a manager, as an example, and you see that they're always calling at 10 in the morning, maybe 10 in the morning is not the best time of day to call that patient. Maybe you need to call later in the day.
So that was going to be, I was going to have 2 things. One was, is the person who responded from the cosmetic surgery clinic that makes 5 attempts, are you on this call, on this Learn at Lunch?
I am on the call.
Do you, making 5 attempts and you want all of those done in 8 hours, or at least started within the 8 hours?
No, not in the 8
hours.
Robocall? I misunderstood the question, that it wasn't within that time frame. So we want to get back to them right away, and usually that's within hours. We use a system called MyMedLeads, which is something totally different in cosmetic. I just thought I could bring a different perspective to this group, because we're so unrepresented or underrepresented out there with medical group management. So, you know, when we're open, we're calling them back within 30 minutes, 40 minutes, 50 minutes. But our practice management EMR system also, we have what's called treatment pathways. And so we put the interest that the patient had in the system, and then it spits out automatic emails and contacts, whether that's text messages, email blasts, and then we have people following up on calls as well. So we pretty much are always trying to reach them, because they reached out to us first.
Sure. So while you don't have the automated system for the calls, you have automated for the other methods of contact, whether it be email or other forms.
Correct.
Oh, that's nice. That's nice. I'm just curious with the attempts. This is a question for everyone. Do you guys, and I'll share what what we do. The first attempt is we will try to send a MyChart message to the patient, and we're counting that kind of the first outreach. And then the second attempt, we make a phone call, and then the third attempt, we make a phone call. Does anyone have a different method, or is it like 3 times that you're calling the patient, or is one? And I just heard, and sorry I didn't get your name, but you know, she's also utilizing text messaging. I'm curious to know, for those on the call, what are your methods for each of your contacts?
Well, Terry, when I was working in a general surgery group a couple of years ago, full-time, after the 3rd attempt, we were required to send a certified letter to the patient just to close that loop. And part of it is that in bariatric surgery, the doctors were reimbursed fairly well, and a lot of those patients would pay cash. So they were willing to pay the $3 or whatever it was for a certified return receipt letter in hopes of getting that huge payoff.
Yeah. Oh yeah. Well, you know, we used to do that. And I mean, one of the things that we were looking at when when I got the referral center, or when we created the referral center, was, so much of our process was so manual. What pieces could we automate? And then that was that certified letter was one thing that I specifically had to reach out to our compliance to ask, do we still need to send a letter, or does an email now, satisfy that requirement? And we were told that the email would be okay now. But yeah, we were sending certified mail, so it was it was just more labor intensive, because now you're printing out pieces of paper, folding it, addressing it, all that stuff. So that was one. So that's something that we changed. But is anyone else doing anything else besides a phone call? I think the text message is. I like the text message. Anyone else?
Yes, I work for NFQ out in Houston, Texas, and we service Brazoria County and Harris County and Galveston County. And we do utilize the phone call and the text message, as well as sending snail mail.
How does your text, and sorry, what is your name?
Oh, sorry. My name is Melly Aloha Bartlett.
Hi, Melly. Oh, that is
Melly. Melly is fine.
How do you, I think text message is something that we want to do. How do you guys, is that automated for y'all, or how do you do that?
So we have templates that we stick to for specific items, because we are really, especially with this pandemic, text has really been a key factor. As you know, I don't know if you do, but I know I do. I screen all my calls. If I don't know that number, I'm not going to answer. Some people have caller ID that does populate our organization's numbers. Others do not. It depends on the service. So, we attempt to call the patient, leave a voicemail if their voicemail is active and has space available. If not, we have, if the patient opts in during the registration, the ability to SMS text. In our system, we have built-in templates that are either an email form that can send a formal letter via email if they have that option. We have scripts literally typed up for in a Word document that we share, copy paste, so that way it is consistent regardless of the user for the specific topic that we're sending to the patient.
Nice.
So do you have a program that allows the SMS message to come direct from the computer that makes that translation?
Yes. So it's built into, we have an open source system that we've really customized for our needs. We've branded it ourselves. So we work directly with our developers that really does look into the different technologies that our system can handle and implements it to what we need.
And there is software out there on the market that people will use to do exactly what you said, Justin. It goes directly from the computer while they're building a record, for lack of a better word. They'll send a text message that says, "Hi, this is so-and-so at blank medical practice. We received a referral from your primary care doctor. We will be contacting you within the next 24 hours by phone. In the meantime, if you would like to talk to us, here's our phone number and call us." And what they're hoping is that the patient will then implement that phone call, because with them doing the calling to you, it shows a little bit more skin in the game, so to say, that they are very interested in coming to your practice.
Our institution out here at Texas Tech Health Science Center is working with a group for that exact software type. Our Department of ENT has not adopted that because telemed for us has not been the biggest push. Telehealth does not lend itself well towards ENT without specialized software typically. So we have not adopted that same software, but as the institution is rolling it out, we're finding it has more of these features, like the ability to SMS text direct from the computer, create that chart, that dialogue that we can track and follow that patient with. So that's why I was interested what Melly, when she said that, what software she was using, if it was similar, and it sounds similar, just very customized for them.
Okay. don't feel like you're missing out, Justin. Our E&T group, they're not doing any telehealth. They opted out of telehealth.
We're trying. We're trying. We have our providers once a month. Each provider is required to hold a telehealth. I did that because our institution pushing so heavily. I did not want somebody to say what you just said about our group is we've opted out entirely. So we have minimized, but not opted out entirely.
Okay. Any other feedback about kind of how your organization is reaching out to patients? Awesome. I see that Tom has some questions for us, and I think it does help us nicely segue into our next question. So the next question was, what is your referral appointment schedule rate? And Tom posted a question to the group about how long it takes to get patients. When you get them scheduled, what is that, I guess, lag time? Can I just start off the 95%? That is amazing. Who is that person on this call? The referral turnover rate of 95%?
No, they were terminated this morning. We're doing too good of a job.
For not getting that other 5%.
I mean, 95% is amazing. Oh, okay, if that person isn't on, hopefully they're not terminated. How about whoever responded with 90% or above or 85%?
I was one of those people. I'm the comment at the bottom is 100%, but I'd be happy with 90 plus.
Okay. What is, I mean, is it actually, because I mean, in looking at patient access benchmarks, and I'm happy to send this out to this group too, the average, and this is, I mean, it is specific to academic medical institutions, but it's like 60%. So
that's pretty low.
Yeah, it is low, and that's why I'm seeing these numbers. And I would say ours for Baylor, if I'm looking at our data, because we do track it. You know, ours is probably around 60% too. So I'm really interested in hearing from those folks who responded with a higher than 60%, you know, schedule rate.
Well, you know something.
I think mine is actually low in cosmetic because it's the patient coming to us. They clicked on something that said they were interested in information. So the fact that only 75% of them answer their phone when we call is, you know, a little amazing to me. You reached out to us, we didn't reach out to you.
Okay, that makes me feel a little bit better. How about, I think, like I said, the benchmark that I've seen on average is 60%. So, you know, if your organization is doing better than that, then, you know, kudos to you. I will tell you that for us, you know, it's either we can't get in touch with the patient or they got their services somewhere else because, you know, not everyone wants to come into the med center, and I totally understand that.
Well, Terry, you know, something that I find interesting is I'm not a biller or a coder, but I understand that you have to hit certain metrics in order to get like an EM code, level 3, level 4, level 5, et cetera. And I was working with a practice at one time, consulting with them, and I would listen to the staff make the phone calls just to hear what they're telling the patient. And I was amazed how many times the patient would say, well, I never requested the referral, or I didn't know the doctor put the referral in for me. So when the staff was calling, they were totally surprised. And it's kind of like, I've always heard that if you write a prescription or you send in a e-script to HEB or whatever, that one issue could sometimes bump you from one level to another just by writing a prescription. I think it has something to do with medical decision making. So, with that same thought, I wonder if you refer somebody, if that puts you up differently as well too. It'd be nice to have a coder on the call.
I don't know that answer, but that's a good question. We do listen to our calls, and Tom's question was, does anyone listen to that? Because it is a bit, I mean, patients have choice. right? They don't have to come to your doctor for that referral. So we have listened and, you know, given kind of feedback. And it's not like, it's not selling salesy. I mean, what we tell our team is that really, and I have personal experience with my dad, right? He didn't schedule his nephrology appointment when he should have 4 years ago. And now we're going through dialysis and trying to get a kidney transplant, you know. And then so I share that story with my team to tell them that, you know, really I am passionate about, you know, about patient access and scheduling, coordinating our patient's referral, because there is quality of life and it really impacts that patient. And they may or may not know it at that time, but that's why we also have to take the time to explain to the patient, you know, why they were referred, give them the background. You know, we saw that, I can see here that you saw our family medicine doctor on this date, and you know, and then per his notes, I'm saying that, you know, he really recommends that, you know, you see the cardiologist. You know, if you would like me to get more information, I can do that. So, you know, we try to kind of make that, help the patient recall why it's important and get them more information if they're hesitant about scheduling that appointment.
Yeah, the one reason I also brought up that about listening to your staff is that depending on who's making the call and trying to do the schedule, you know, they may have been told that morning that Thursday's schedule is really light. We need everybody that we can get scheduled on Thursday that we can. So if that person is calling the patient and they're trying to push Thursday only on that patient, they can't do it on Thursday, but they seem very persistent, that sometimes can be a turnoff to somebody that, you know, Thursday doesn't work with my schedule. I can come next Wednesday. And it's all about, I think, giving options. You know, when you're talking to a patient, look at your schedule, see what you've got open, ask them things like, would you prefer morning or afternoon? Because many people, they don't want to be out at 3:30 in the afternoon in a busy part of Houston or San Antonio. And then the appointment's running late. Now they're in 5 o'clock traffic to run back home. They'd rather get up early and go. And I think that while your first attempt may be to fill that schedule, ultimately you're trying to get that patient scheduled into your office.
Yeah.
I hate to change subjects as we're running running out of time. Kimberly had a question I wanted to get to. Depending on diagnosis, 0 to 2 week, if patient is wanting to schedule with one of our seasoned MDs, it could take a couple of months. Do you create a patient chart for every patient that you receive records on? Our system only allows us to send text or email once the chart has been created. We usually wait to create the chart until the patient has scheduled. Kimberly, that is exactly the problem I run into in my system. That exact same situation. Does anybody have?
You do, Justin?
I'm sorry?
So you create the chart?
We aren't allowed to create the chart until until the patient has been scheduled. So it prevents us from being able to send the text or the email prior to. So earlier, Terry, you had asked you send out the initial email and then call for contact 2 and 3. We actually can't do that because we can't our system doesn't allow us to send that email until the chart's created, and we can't create a chart until after they're scheduled. So it limits our options to contact prior to create the schedule the appointment.
A lag, yeah. No, we have the same issue where we have to transcribe the referral, and if it's a new patient, we have that same issue where we can be caught up on our referrals that are in our work queue because those are patients who are currently in our system already. We have a chart for, but for those completely new, there is an additional lag of getting, going through the referral, checking to see if they're in our system. And then once we do that, setting up a chart for them. I don't know if anyone on the call, I know we're up on time, but if anyone has a good creative solution for this that you could share with all of us, because it seems like this is something we all struggle with.
What I have seen is I've seen both ways. I have seen where the policy of the practice is that when you get that referral, you build a basic chart based on what you got from the PCP, including the information. And then you try to start contacting that patient. So if you look at it from that perspective, then if you don't get that patient into the office, did that person waste their time loading all that information? Then I've seen others that, depending on what type of practice management system they have in EMR, that if they're billed by the number of patients that are in their system, and it gets to a certain point where maybe it bumps up because now you hit that threshold where, you know, typically our system, we price it based on this amount. And when you hit that, it goes into another. I could see where a physician would say, don't load them up until we actually have that appointment scheduled. But if you don't put them in from the get-go, I think that when you're trying to run analytics as a manager, you're not getting the entire picture.
Yeah. Yep.
Our system's big argument. We're a pretty conservative system. Their concern was if we load them into the chart, if we load a chart into the system, do we then become medically responsible for that patient that we've never actually seen because we've taken on we've created not an encounter, but created a chart for them in our medical record. And so that was the big hesitation from our system. Kimberly, if you have the ability to chat, do you happen to know why your system?
We already have a pretty slow system as it is, and our IT department has really stressed that we should not add any additional charts that are not necessary because it could delay everything else.
Oh
Yeah.
man. Yeah. I think one of the things I know that for us, so we're on Epic. So Epic has a solution, but I mean, we're having difficulty implementing this, but it's called Epicare Link. And basically referring providers, even though they don't have an Epic system, they can submit their referral through this kind of online platform, right? And then what that would do is it would automatically pull that patient data into the system. So it would help you create that chart. So it would automate that process of getting a referral who isn't, you know, who is a new patient and helping the creation or automating the creation of that chart. But again, I think that's relatively new, and it's hard because you're asking your referring providers to do this new step, you know. And usually, I mean, we obviously want to cater to our referring providers to make their life as easy as possible to refer to us. And if they're used to doing, you know, sending it in a fax or making that phone call, it's really hard to get them to try to change something that already works for them and not put any more onerous work on them. But I know that we are over time. I do want to, if are there any other questions or comments that maybe we haven't covered that anyone on the call would like to bring up? All right. Well, you guys, I mean, Justin, you want to say closing remarks?
Oh, no, thank you everybody for joining in. We really appreciate it. We appreciate the questions that came through and the responses, filling out the surveys. Keep doing that. We were toying with the idea just prior to this meeting of when we send out those questions to see if we can get a little more than 6 responses, because we had quite a few more than 6 on the call here today. Just pay attention for those coming from Texas MGMA. We don't know if that's going to change, but we're looking into that, because the more respondents, the more we have to pull from to discuss and better ideas. We can all share best practices. Thank you again, everybody, for coming in. And as Betty had just mentioned in the chats, if you happen to miss a week, these are being recorded. You can check those out at search Texas MGMA for the YouTube channel. And these are all posted there, so you can catch up with ones you've missed.
And Betty, is it okay? I was going to say the question about the robocall vendor information, and I'm also happy to share the benchmark data that I was referencing from that patient access collaborative. I can give that to Betty, and she could just post it at the same site for those who asked for that information.
You bet. Happy to.
One final comment. It is time to renew your dues for 2021. If you haven't already done that, you should have received at least one email from Texas MGMA. There'll be others that will be coming out soon. We need everybody to continue their membership with us. And this is a program that we just recently started as far as following up a few days later with Friday Focus. If you like it, please let us know. If you don't like us, we'd like to know that too. And then also tell your friends.
Yes.
All right, everybody, y'all have a great day. Have a great rest of your lunch hour, and we'll see you soon.
Thank y'all. Bye.
Thank you.